Thank you, Elias, for the kind introduction. And what a wonderful panel I can see there, all good friends. And also the speakers in these sessions. I can't imagine of any best selection of speakers. Zachary, Antonis, Theo is coming after me, Vlasis, and wonderful talks I have watched so far. So I'm a testament that complications of TAVI also occurred in the operators, not only in the patients. So that's why we should be careful and take care of ourselves. That was a very difficult TAVI 2 days ago, and that it took some effect on me. But the meeting was ready, everything was set up, so I don't think this personal problem has any impact on the flow of the meeting. So I really enjoyed Antonis' presentation and Vlas's presentation earlier, and I think this is a testament of why we need the surgeons, like Stratis said earlier, and not just any cardiothoracic surgeon, but we need the cardiothoracic surgeons that are very, very experienced, because the cases that will be left for surgery in the future will be those select and very difficult cases, not the simple ones. So my talk is about MAC, and I think you would all agree that MAC is the worst of the worst, and is the worst pathology you can find in the mitral valve, because it usually comes with a combination of mixed mitral valve disease, both stenosis and regurgitation, that makes all the tools we have for treating stenosis or regurgitation individually and not valid in this pathophysiology. The disclosures and our heart HYGEIA and the pathophysiology of the calcifications in the mitral aortic valve is very well presented by a fellow Greek in a recent review in the European Cardiology. It's not of my current speech, but I recommend that you go back and read this for a scientific background and the theory behind the calcifications of the leaflets. Just the presence of MAC in a patient is a very bad indicator. So in this echo study of thousands and thousands of patients, those patients that had MAC, they had the worst mortality during follow-up. And of course, we all know that MAC poses very serious risk in surgery. We can have lethal skeletal tears that we cannot correct, injuries from the sutures, dehiscence of the bioprosthetic valve, rocking bioprosthetic valve, and of course, paravalvular leaks. And calcification comes in many patterns. It can be symmetric or asymmetric. It can be something like a combination of cheese and MAC, the caseous MAC, as we can see here, where we have accumulation of different quality of calcium within the egg cell of the main calcium. It can come in beads, beaded MAC, like you can see here. And also we have the MAC queen concept when we have the calcification, but we have a hat on the top, which is a prosthetic valve, either a TAVI valve or a surgical valve. This is the MAC queen pattern, as you can see here. And we had the recent publication of Maya Guerrero of how to classify these MAC classifications, and we give points depending on the thickness, on the distribution, on the trigon involvement, and the leaflet involvement. And this system, the score, is very important when we decide to do something for these cases. Let's start with a couple of cases we had the chance to treat in the past. This is the first MAC we did our team. So you see a patient typically with mixed mitral valve disease, both regurgitation and stenosis. You can see the calcification around. This is a MAC queen patient because we had implanted TAVI sapient valve some years before in these patients. And this is the assessment. We do the detailed assessment with the CT scan. the planning of the valve, and we like to do this assessment with 3D printing of the hearts of these patients when we want to do MAC cases, the transcatheter. So we like to simulate the procedure, we implant the valve, and we just visualize what is the effect, how the valve tilts, if there is any paravalvular space around it, and this is very, very helpful. So this is what we did in these cases. We're satisfied that there was no LVOT obstruction, there will be no paravalvular leak with the selected size, and we went transapically. This is how we're going in the first cases. And you see the implantation of a Sapien 29 valve, and you can see two Sapiens, one in the aortic valve, the other in the mitral valve. These valves sat very well. There was no paravalvular regurgitation, and the final result was very good in the long term for this patient. And on the other edge of the spectrum, this is another patient that we embarked to do the same procedure, very severe MAC, as you can see, and it was considered to be inoperable because of the thickness, the extension, the distribution of the calcification. So our measurements were like borderline. You see at one level, the area was 700 millimeter, which is at the upper end for a 29 millimeter valve. But at other levels, it was larger than this, and the diameter was like 20 by 32 millimeters. So it was a very borderline case, the beginning of our experience. And we proceeded to do MAC procedure. The neo-LVOT was considered to be adequate, and we did all the screening. And we can see here that if we take a 29 Sapien valve and you overinflate it, you reach to this area to 742, which in this calcium we thought it would be enough. So this is the implantation, again transapical, with 5 ml of contrast more. And initially the procedure was uncomplicated. The patient went very well, and we had the patient every day echocardiography, and we were watching the valve and the position. And then the day of the discharge, the 5th day, the patient started having shortness of breath, and we noticed that the valve had slipped and migrated a little backwards compared to the other days, and we had this paravalvular regurgitation. So this is from the table when we tried to save the patient. Unfortunately, we didn't make it. And this is the reason of why we need to flare the mitral valve when we do it in MAC. So MAC patients, when you do a transcatheter implantation of a Sapien valve, we have, this is the largest registry of more than 100 patients. You see those patients are very high surgical risk score, 15%. In this registry, it was an equal share between transeptal and transapical. It's an older registry. And you see high numbers of problems, 11% LVOT obstruction, 4% valve embolization, need for a second valve in 15%, and conversion to surgery in 3 to 4%. And you also see a very high mortality, even larger than the STS score, 25% in the 30 days. Of course, during the course of this study, there was an improvement because they learned to use CT scan assessment and sizing, but still you can see in the later cases the 30-day mortality was close to 20%. In other registries, again, the same results, not very encouraging. You can see always double-digit mortality in 30 days when we embark to do these cases. So we use this recent score, and this is how we use it. And as you can see, the score is from 0 to 10. The more calcium you have, the better for this case. And you see here that the more calcium you have, the less valve migration, the less PVL, and the better the result. Of course, when you have MAC, the neo-LVOT area is always smaller than when you have to do valve in valve on valve in MAC. So this is the printing we do and how we sets for the LVOT, the view from the ventricle and the view from the aortic valve. And then we implant the valve of the size we intend to implant, and we check from the ventricular side and the atrial side if we have any problems of PVL. So in cases that you suspect to have an LVOT obstruction, transcatheter electrosurgery and alcohol septal ablation, pre-empty alcohol septal ablation, are used to reduce the chances of this event. And the laboon comes in many flavors. So you can go from the aorta to do the classic laboon. You can go transeptally to do the antegrade balloon. You can do the tip to base balloon when you create a loop. And all these are used rarely in cases that you cannot do anything else. So other also techniques are proposed, like to destroy the anterior leaflet of the mitral valve with a balloon, just to go through with a wire and then to dilate it with balloon and destroy it. And another position is to do a modification using endoscopic scissors like this. And this is a case that we tried this, the modification with endoscopic scissors. You can see it's again a mixed mark with stenosis and regurgitation. You can see the anterior leaflet is very calcified, nothing moves. These are the gradients, 11 mean gradients. And there was also an aortic valve prosthesis there with the expected velocity through this. This is the calcification, and this is the beads of the calcium, as you can see, that are extending below the annulus of the mitral valve. And we did our measurements, and we thought that even if you put the valve very atrially, there will still be a problem, and all the measurements, as you can see, of the neo LVOT were like below 1 square centimeter. So this is the setup through an Accentra sheath that we use for transapical TAVI. We use this thoracoscopic scissor, and we went initially transapically, of course, through the valve, and then you can see the scissor that is advanced to encapsulate the anterior leaflet. And here you see the opening and the closing of the scissors having inside the anterior leaflet and cutting the anterior leaflet, and here fluoroscopically the same thing. And we did it twice on the anterior leaflet. You can see it again here. And immediately we saw that there was a piece of anterior leaflet that was detached and moving. So we certainly modified the anterior leaflet. We also see the movement here. That was the cut we created. And of course, more mitral regurgitation, as you can appreciate here. So we implanted the valve, and we had a very good result, stable position, and we used also a sentinel because of the calcium for protection of the brain. And this was our result, no regurgitation, and as you can see, very nice sitting of our valve. And the gradient remained in the aortic valve unaltered, as you can see here, the same day and the following day, 2.4 velocity. And closing my presentation, uses of TMVR systems like Tendyne in MAC is undergoing investigation. The MAC cohort has finished of the study, but the problem is in the main study that has difficulties to recruit, and like Vlas said, we don't know if it will ever finish. Hopefully, we'll see the results of these sub-studies of the Tendyne. And as you can see, examples that Tendyne was used. But we know from the initial roll-in experience from this valve, as you can see, these are the first 103 patients. Mortality is 7%. The 30-day mortality is 7%, which is really high. And I think it reflects the transapical nature of this procedure. And if we go to transeptal, like with the alta valve, this number hopefully will be a lot lower. And this is the other valve that is undergoing investigation, the Intrepid. Also, the Apollo trial has a MAC cohort, and these are examples of MAC patients that are accepted for this valve. But I think the surprise will come from the M3 system. The Encircle trial has already has been completed, and we'll have the results at TCT this year. And rumors say that this will be the first valve to get CE mark and FDA approval within 2024. So this is the valve we all know, the Sapien valve, that is implanted within a dock. As you can see, this is a dock that you go and put into the mitral valve apparatus before you implant the valve. So the main study has finished, the FAIL-T registry with 100 patients is finished, and the MAC registry have finished. And hopefully we have these results very soon. And with that, I would like to thank you for your attention.
Thank you very much, Kostas. Very nice, enlightening presentation. Once again shows how things in the difficult areas, or as is MAC, that, as I said to Dr. Danyas 30 years ago, we were going to surgery without knowing what we were going to see. We didn't have echo into the operating theater. And now how nice solutions and nice results from the patient. So please stay with us at the end so we can have some questions, because our first enemy is the time. 15 minutes left, but probably we're going to extend it to 25 because we started a little bit later. And I have the privilege to introduce Dr. Theodore Kofidis, professor, chairman,